Good afternoon, dear colleagues. Thank you for the invitation. My name is Alexey Aksyonov. I'm doctor oncologist. Today I present our team, which consists of a radiologist, a surgeon, and an oncologist. We are doctors who have concentrated our skills and experience on the early diagnosis of breast cancer and have been working on this for a long time. I am glad to present you our work. I hope you will find it interesting. Today we will talk about the pathology of the breast, which still doesn't have a standard diagnostic protocol in the world and is characterized by often mistake in diagnosis and treatment. Actually, complex breast cyst and pathological nipple discharge aren't the most common breast pathologies, but they are definitely the most difficult breast pathology to diagnose. In addition to diagnostic difficulties, this pathology has a high risk of malignancy and heterogeneity of histological diagnosis. So, many borderline histological diagnoses and a high risk of cancer in patients with complex breast cyst and pathological nipple discharge push us to resolve the issue of obtaining adequate biopsy material and the diagnostic stage, which will make it possible to develop personalized treatment or an individual diagnostic follow-up plan. Today, more than 80% of biopsies are performed under ultrasound guidance, but in cases with complex breast cyst and pathological nipple discharge, ultrasound guidance is limited. For example, fine needle biopsy is the most common type of ultrasound-guided biopsy, but it is not able to determine the extent of invasion of the biological and genetic type of the tumor. This type of biopsy is not recommended for use in patients with complex breast cyst and pathological nipple discharge. In case of complex breast cyst and pathological nipple discharge, the diagnostic and navigation capabilities of ultrasound may be limited. In particular, according to Kulali et al. 2022, for complex breast cyst more 2 centimeters, at 100%, the sensitivity, specificity, and accuracy of ultrasound decreased by 50.4 and 54.8 respectively. The study included 124 cases of complex breast cyst larger than 2 centimeters corresponding to ultrasound category virus 3, among which 9 malignant lesions were identified, which amounted to 7.2%. The decrease in the navigational potential of ultrasound is most noticeable in situations with atypical complex breast cyst echosemiotics, when the evaluation of echo patterns according to Bayer's criteria becomes uncertain, as for example in category 3, Pistoles et al. 2019. The study included 122 cases of breast tumor corresponding to ultrasound category virus 3, among which 7 malignant lesions were identified, of which this amount to 5.7% and significantly exceed the declared risk of category virus 3 American College of Radiology. A more significant obstacle is the sudden loss of ultrasound visualization of intracystic neoplasia after fine needle aspiration of the liquid component. This is indeed a common problem with small intracystic tumor. In the video, you can see a tumor in a cyst 3 mm in diameter, which is clearly visible in the presence of fluid in the cyst and a complete lack of visualization of the tumor after aspiration of the cyst. Recently, MRI has been increasingly used to monitor breast biopsies, but only large medical centers are equipped with this equipment. In addition, this method has many disadvantages. For example, the impossibility of fixing the breast during a biopsy, removing the patient from the magnet area for biopsy, a high probability of displacement of the needle tumor position. Endoscopy-guided biopsy is also available in a small number of medical centers, and from our point of view, is not sufficiently used to guide biopsy of complex breast cyst and intraductal breast tumor. However, we have experience using endoscopy for navigation, which I would like to demonstrate to you. We use Karl Stoss endoscopic equipment and special forceps and biopsy basket, as well as modern laser technology. Today, the technique, especially forceps biopsy, need further improvement, which is what Professor Felipe from the Netherlands is actively doing. We use endoscopic mammocystoscopy, which provide direct visualization of intracystic pathology and the possibility of taking a biopsy. In the video, you can see how the technique is performed on an outpatient basis. Under local anesthesia, the cyst is drained with a catheter, sanitized to clean liquid. The direction of the catheter is controlled using ultrasound. Then an endoscope is inserted into the cyst cavity through a catheter, and we get the opportunity to visually assess the tumor, instrumental palpation, and biopsy. In some cases, it is possible to completely remove the tumor using miniature forceps and laser ablation of the tumor-grown area. However, this method also has its disadvantages. Not enough study and need further improvement. Its high quality use is possible with the help of a trained assistant. Visual control may be impaired if there is minor blending in a small confined space of a duct or cyst, and it is not possible to assess the radicality of tumor removal. Diagnosis of pathological nipple discharge using ultrasound is much more difficult. With pathological nipple discharge, we most often see ductectasia, but a very small intraductal tumor cannot be detected using ultrasound diagnostics. In cases with pathological nipple discharge, ultrasound-guided biopsy is possible in a small number, approximately 20% of patients, due to the difficulty of milk duct scanning around nipple and the small size of intraductal neoplasia. In cases where there is a pathological nipple discharge, but no ultrasound confirmation, we use ductoscope to identify the source of the pathological nipple discharge. We have been using ductoscopy for more than 10 years, and its capabilities in the diagnosis, preoperative localization, and treatment of intraductal pathologies are significant. In the video, you can see the process of gradually expanding the duct using bulges of various diameters to the diameter of the endoscope, which is 1.6 millimeter in diameter, and inserting the endoscope into the duct through the nipple. Inspection of the duct occurs under local anesthesia. Most patients feel well during the endoscopic examination and do not require general anesthesia. When a tumor is detected, we perform instrumental palpation to determine the density of the tumor. And if the tumor is soft, we use a special endoscopic basket for biopsy. In cases where the tumor is dense, we use endoscopic forception to obtain histological material. In most cases, the material obtained is sufficient for histological examination. Our work, optimization of diagnosis of surgical treatment of intraductal tumor on the breast 2090, confirms high rates of accuracy and sensitivity, but the low specificity rate for ductoscopy is associated with the distant location of the intraductal tumor more than 3 centimeters from the nipple, and the tumor not failing within the limits of breast resection, which leads to 35–40% of cases of false negative result. In our work, we were able to increase the specificity of the technique to 100% using double marking on the intraductal tumor under ultrasound and mammoductoscopic control. In 77 patients included in our study, a non-palpable intraductal tumor was accurately removed and histologically confirmed. Our attention was drawn to pneumocystography and ductography as method for additional diagnosis of complex breast cyst and pathological nipple discharge. We set ourselves the goal of studying the possibilities of stereotactic biopsy under the control of pneumocystography and ductography in patients with complex breast cyst and pathological nipple discharge. To navigate in case with complex breast cyst, we used radiological targets such as internal shadows, thick walls, thick septations. The techniques was performed in this way. First, using a thin needle, we aspirate the contents of the cyst completely. Then the cyst cavity was filled with air. After filling the cyst with air, the volume of air introduced corresponded to the volume of fluid removed. The patient performed mammography in standard projection, and the resulting targets were used to guide stereotactic biopsy. In some cases, when the cyst was of an impressive size, we kept the catheter inside the cyst during the biopsy to be able to add air and enhance the contrast of the pathology. For a complex breast cyst, the accuracy of ultrasound and pneumocystography didn't differ significantly. 64.3 and 58.9% respectively. In total, we performed 9 biopsies under the control of pneumocystography. All intracystic neoplasm were benign. Unfortunately, ductography as a method is used less and less. In our opinion, this is completely unjustified. Although highly accurate ductography has a low specificity due to the lack of the possibility of preoperative marking on the tumor, which complicates the search and removal of the tumor in the duct, and also leads to an increase in the volume on the operation. However, the use of ductography in conjunction with stereotactic biopsy makes it possible to obtain adequate histological material for research. To navigate in case with pathological nipple discharge, we used radiographic targets such as filling defects and amputation lines. The technique was performed in this way. A contrast agent in 0.5 to 2.0 milliliters was injected into the secreting duct. The hole in the nipple was sealed with a plaster so that the contrast did not leave the duct, after which mammography was performed in two projections. After identifying the target in the duct, the patient was transferred to the stereotactic biopsy room, where targeting was performed using a stereotactic attachment, and the biopsy itself was performed 4 shots. We performed 35 biopsies under the control of ductography and identified 3 intraductal cancers. The first experience with pneumocystography and ductographic-guided stereotactic core needle biopsy shows that it is a technically simple procedure that doesn't require complex equipment and can be performed in an outpatient setting. Obtaining a stable and, importantly, structured image of intracystic and intraductal neoplasia using pneumocystography and ductography together with the technique capabilities of stereotaxis ensures the successful performance of a core needle biopsy on a fixed breast with a targeting accuracy of up to 0.1 centimeters and obtaining a sufficient amount of biopsy material without frequent used for complex breast cyst and pathological nipple discharge traumatic open biopsy. An additional advantage of stereotactic core needle biopsy under the control of pneumocystography and ductography is the presence of a puncture channel and hemorrhage around it, which is a kind of marker of the need for open surgery. On the other hand, the absence of oncologically suspicion images avoid unnecessary surgery in 73.2% of patients with complex breast cyst and in 20.4% with pathological nipple discharge. Of course, user experience and the effectiveness and feasibility of pneumocystography and ductography in patients with complex breast cyst and pathological nipple discharge is needed, which we will continue to conduct and provide you with more detailed information in the near future. Thank you for your time. If you would like to contact me to discuss this information, write me an email. I will be happy to answer you. Thank you again for your time. See you again.